Good morning, students. Am I audible? So briefly revise about the previous class. What did we talk in the previous class? Yes, Jana? Jana Brahman. You can type in the chat box. Development of nervous system. Okay, very good. How it develops? What is the inducer? Why the neural tube, neural groove, neural crest, neural plate, everything develops just against the notochord, because the notochord acts as the inducer. So the changes take place in the ectoderm just above the notochord. Okay. What else? How the neural crest cells are formed. Yes, please answer. Sania, Maria, please type your answers. It's useless to take the class if you are not responding. I know everything's given in the book and you can access the internet and study whatever you want. But still, teaching at least helps you in some way. लाइबा, आप लोग ज्वाइन करके चले जाते हैं, मीटिंग ज्वाइन कर ली और उसके बाद छोड़कर भाग गए। इज दैट सो? सुमैया, Shoaib, what are your answers? All three Zainabs are there. Any one of you can answer. अभी आपको डेवलपमेंट नहीं आ रहा है. How will you study gross anatomy? If you are aware of the development, gross anatomy becomes a bit easier. Although anatomy as a whole is very difficult, but if you are acquainted with the embryology part, the gross anatomy is much easier as compared to without knowing the embryology. नहीं बोलेंगे? मैं भी ऐसे ही बैठ जाऊं? कुछ फायदा है क्लास लेने का? नहीं. We are almost approaching the end of systemic embryology. Today we are going to talk about the respiratory system and the body cavities development. And then maybe in the next few classes we'll have the models so that we can revise all those models. लेकिन आप बोलेंगे नहीं, आपको कोई response नहीं होगा तो it will be useless. It's a futile exercise. Shall I start? Any more students joining in? कुछ तो जवाब दीजिए, ऐसे कैसे बैठे हैं बिल्कुल खामोश? या तो मेरी आवाज नहीं आ रही है या आप लोग बोलना नहीं चाह रहे हैं. व्हाट्स द रीजन? शाहनवाज, आर यू देयर? क्या बात है, कोई जवाब क्यों नहीं आ रहा है? You people are not interested in learning anything? You don't want to attend the class? सही. अव्या, अव्या गर्ग.
यस मैम.
जी, क्या बात है? समझ में नहीं आ रहा है, इंटरेस्ट नहीं आ रहा है? What's the reason? I know it's a bit difficult to cope up with the online classes, but still कुछ तो पढ़ रहे हैं ना. कुछ नहीं पढ़ने से तो बेहतर है कि कुछ पढ़ रहे हैं. And the efforts we are putting in are a part of it. थोड़ा आपको भी एफर्ट लगाना पड़ेगा ना, तभी तो समझ में आएगा. चलिए, I'm sharing the screen and then we'll start with the respiratory system and the body cavities. Is the screen visible? I have shared the content along with the development videos in the Google Classroom. So if the videos are not visualized here, you can go to the Google Classroom later on and watch all those videos of respiratory system development and the body cavities. So the learning objectives for the today's class: by the end of the class, you should be able to describe the development of respiratory system, describe the development of all the body cavities, major body cavities, that is pleural, pericardial, and peritoneal. Out of this pericardial cavities, we have given you an outline in the development of cardiovascular system. So we are not going to discuss the pericardial cavities here, but we'll definitely talk about the pleural and the peritoneal cavities. And also explain the anatomical basis of the associated anomalies. So the respiratory system, it consists of nose, nasopharynx, oropharynx, larynx, trachea, bronchi, and lungs. This respiratory system initially derived from the primitive gut tube. That is, when it is derived from this part, the foregut, it definitely is endodermal in origin, because the GIT, that is the gastrointestinal tract, is basically endodermal in nature. So the diverticulum that is formed from this endodermal structure is also endodermal. At approximately the fourth week of intrauterine life, an outpocketing appears in the proximal part of the gut tube, that is the foregut. And this outpocketing is given the name of respiratory diverticulum. See, this is an outpocketing, that is tracheobronchial groove. It divides. Initially, it is continuous with the foregut, but then a longitudinal ridge is formed, known as tracheoesophageal septum. Tracheoesophageal. So, as the name suggests, this septum is lying between the trachea and the esophagus, and it demarcates the trachea from the esophagus. This respiratory diverticulum, it divides into two buds, which are going to be the future lungs. So these two buds, they become the right and left primary bronchi, and then these bronchi, they proliferate further to give you the secondary and the tertiary bronchi. As you have studied lungs in the thorax, so it will be quite easy for you to understand how this development from the splanchnic mesoderm. The two buds are dividing from that diverticulum, and they are like, left one is more transversely placed and the right one is oblique. These are known as tracheal buds, and the tracheal buds, they further subdivide into the bronchial buds, forming the bifurcation, and the bronchial buds, they develop in a branch-like pattern, that is of a tree. These bronchi, they supply the different lobes of the lung, as in the case of right and left, you can see here, the upper, middle, and the lower lobes, and the upper and the lower lobes. So to summarize the respiratory system development, it is developing from a median diverticulum, lining is endodermal in nature, and the connective tissue, cartilage, and muscle is derived from the splanchnopleutic mesoderm. Whereas tracheobronchial groove, It lies caudal to the hypobronchial eminence, and is present on at the level of the sixth arch. So this distal part separates from the esophagus, whereas the cranial one continues with the pharynx. Caudal end जो है वो bifurcate हो जाता है, and that becomes the lung bud, whereas the cranial part is forming the larynx and trachea. So that bud, or you can say that tracheobronchial groove, that further subdivides and divides to form the bronchi and the lungs. Now this lung bud has got lobar bronchi and the segmental bronchi. That is, various segments of the lung are supplied by these segmental bronchi. And the caudal part of hypobronchial eminence is responsible for the development of epiglottis. That we have studied when we were talking about the development of tongue. So this communication between the diverticulum, that is the respiratory diverticulum, and the pharynx is persisting in the form of inlet of the pharynx. And these divisions are like this. As I've told you, they are, left one is more transversely placed than the right one. Two subdivisions are there, and they represent the lobar and the segmental bronchi. Two lobar bronchi of the left side, whereas in the right side, three lobar bronchi are there. Now, this is about the lungs. Total number of divisions of each bronchus, 17 before birth, and 6 more are added to it after birth. Alveoli are formed by the expansion of the terminal parts of the bronchial tree. And the lung parenchyma developing from the lobar bronchi are separated from another by mesoderm. The mesoderm is responsible for the formation of pleura, and these lobes are separated by fissures. Pulmonary circulation is established early in fetal life, and most of the blood is short-circuited initially through foramen ovale and ductus arteriosus. Foramen ovale, ये कहाँ present होता है? Do you remember? When we were talking about the cardiovascular system development, we talked about foramen ovale. Where is it? Shanavaz? Where is foramen ovale? Am I audible, Shanavaz? कुछ भी याद नहीं आप लोगों को. Between right and left atrium, yes, interatrial septum. Very good. So the amount of blood circulating through the lung increases, and by the 7th month of intrauterine life, the circulation is responsible for providing oxygen, and hence the viable infant is born. Now coming to the anomalies of this development. Tracheoesophageal fistula. It's a direct connection between the trachea and the esophagus. It can be congenital or because of some surgical procedure. The congenital cases occur if the TO fistula fails to form fully or forms abnormally. And in that case, esophagus empties into the trachea, or esophagus is landing into the trachea. It is either ending into the trachea, or there's a blind tunnel, and then there's a communication between the trachea and the esophagus. Again, another picture of the same. These I have written, but various stages are there when the bronchopulmonary segments are forming. there are 3 stages: pseudoglandular stage at this week of 8 to 16. These are different stages shown here for the formation of the airway, that is bronchi. The trachea and primary bronchus, lobar, and segmental. Yes, any problem? Yes, Tuba? Segmental bronchus, they are at different stages in 3 to 7 weeks of intrauterine life. Then there is pseudoglandular stage where the bronchioli and the terminal bronchioli are formed. This is how the structure is. Then there is canalicular bronchi or the canalicular stage at the 17 to 27 weeks of intrauterine life, where the respiratory bronchioli are formed. Then there is a saccular stage in which the alveolar ducts are formed at 28 to 36 weeks, and the alveolar stage where the alveoli are formed from 36 weeks of intrauterine life to 3 years up till the child is attaining the 3 years of age. These are different stages. From 26 weeks onwards, the alveoli, they have these alveolar cells, that is type 1 pneumocytes and type 2 pneumocytes. Type 1 pneumocytes are basically simple squamous epithelial cells and they comprise 90% of the alveolus, whereas the type 2 pneumocytes are cuboidal cells and they are responsible for the production of surfactant. So surfactant is basically amphipathic, meaning by that it is able to bind both the hydrophobic and the hydrophilic molecules. Like you say ambidextrous, as in the case a person is able to use both his hands, right as well as left. So that is amphipathic, both ice to water and air will collapse, and this reduces the surface tension. When the surface tension expands at greater volumes and the lungs are able to expand with minimum effort required. In case of respiratory distress syndrome, if the baby is born before the development of type 2 pneumocytes, surfactant won't be produced. So they will have difficulty in expanding their lungs to take their first breath. That is why 7 months viability is very important, because at that time surfactant is produced. In case of preterm delivery, certain cases it is unavoidable. The mother is given glucocorticoid to stimulate surfactant production in the fetus, so that this respiratory distress syndrome is bypassed. Then there could be development of trachea that could be anomalous. Tracheoesophageal fistula we have already talked about. Then there could be diverticulum. Accessory bronchi may be present, or there could be absence of trachea altogether. That's a very rare condition, but it might be present. In the case of lungs, any of the lobe may be deficient, fissures may be abnormal, then fissures may be absent also. Agenesis and hypoplasia, that is underdevelopment of lung, may be there. There could be an accessory lobe that is supplied by bronchus arising from the esophagus. Sequestration of lung tissue may also occur. Lung hernia and displaced bronchi. These are some of the anomalies that may arise while the development is taking place. Then we come to the development of body cavities. It is not to study, but if you go back to the general embryology, third week of development, when the head and tail folding and the lateral folding is occurring, you find that there is a horseshoe shaped structure from the lateral folding. That is this intraembryonic mesoderm, which divides into three parts. What are they? Intraembryonic mesoderm is dividing into pharyngal, intermediate, and lateral plate mesoderm. Lateral plate mesoderm is basically responsible for the development of intraembryonic coelom because of the cell death, and these cell death produce small cavities which finally coalesce together to form a larger cavity. Now this intraembryonic coelom is in communication with the extraembryonic coelom. See this diagram. This picture is showing you the lateral folding of the embryo. We have models also where you can see there are lateral foldings as well as head and tail foldings. So this intraembryonic coelom is formed. It's in the form of a horseshoe-shaped structure. So till now, till this slide, I have already told you, because this is basically the revision of the general embryology from the third week of development. Right and left sides, they are in open communication initially with the extraembryonic cavity. And when the body of the embryo folds, that is head and tail folding occurs, then this connection is lost. So in this manner, a large intraembryonic cavity is formed that extends from the thoracic region to the pelvic region. And this intraembryonic cavity is basically responsible for the formation of the pleural, pericardial, and the peritoneal cavities. In the cells of somatic mesoderm, they form the parietal layer, whereas the splanchnic layer is formed from the visceral layer. And that is covering the abdominal organs, lungs, and the heart. Viscera is covering the visceral organs, and the outer layer is the parietal layer. See, this is horseshoe-shaped cavity from the lateral plate mesoderm that undergoes changes in the form of cell death, and these cells, these cavities, they coalesce to form a larger cavity. So initially, these cavities are connected by a pair of narrow pericardio-peritoneal canals. Pericardio-peritoneal canals. These canals, they enlarge to form the pleural cavities. And this is a head and tail folding here shown. The pericardium is lying ventrally. And these pericardio-peritoneal canals, they are like, they wind backwards on either side of foregut. See, if you see this picture, this is the foregut. Pericardial cavity is this one. And the pericardio-peritoneal canals, they are present on either sides and they are winding backwards. Okay. And lung buds, they now invaginate these canals. As you can see in the picture B, these lung buds are formed by the respiratory diverticulum and they invaginate these pericardio-peritoneal canals in this manner. Fine. So this pericardio-peritoneal canal finally then forms the pleura because it is covering the lungs. Serous layer and parietal layer both are there. Now this pleural cavity is communicating with the pericardial cavity through this pericardio-pleural opening. This is pericardio-pleural opening. Pericardial cavity is over here and the pleural opening is over here. So communication is now between the peritoneal cavity as well as with the pleural cavity. And they are through the pericardio-pleural opening and the pleuroperitoneal opening. Right? See, there's the pericardial cavity, pleural cavity, and the peritoneal one. So if you see here, the communication is between the pleural cavity and the pericardial cavity through the pericardio-pleural opening, and there is another opening that is pleuroperitoneal opening. In this manner, the pleural cavity is in communication with the peritoneal membrane too. And later on, what happens is the separation is, this opening is closed by two membranes, that is pericardio-pleural membrane and pleuroperitoneal membrane. Fine. So the closure occurs. And here there is of septum transversum. See, if we go back to the previous slides, this one is septum transversum. It's lying where the hernial folding occurs. Septum transversum is responsible for the formation of liver, as we have already talked about while we were discussing the gastrointestinal tract. A part of this septum transversum is responsible for the formation of another cavity. Now, when the lung size is increasing, the cavities, pleural cavities, they extend into the mesoderm and they come to lie lateral and ventral to the pericardium. Lateral and ventral. This is how the pleural cavities are expanding. See, these two are the pleural cavities on each side, and this is the pericardium. So when the expansion occurs, there is lateral and ventral expansion. This manner. Lateral and ventral expansion. And the separation between the two is the pleuropericardial membrane. As we have talked about in this is pleuropericardial membrane. Now coming to the peritoneal cavity, the horseshoe-shaped structure that is formed initially as the intraembryonic coelom. Now the two halves, they remain separate in the cranial part, like this. And the attachment is there in the midline. This communication is there, horseshoe-shaped swelling is there, or you can say horseshoe-shaped cavity is there. So the two halves, they remain separate in the cranial part of the abdomen and the mesentery of the primitive gut that is present on the posterior abdominal wall is in the midline initially. Now, as a result of rotation of the gut, we have already discussed in the GIT development. Some structures, they become retroperitoneal, and the mesentery, the attachment of the mesentery becomes a bit complicated. So the peritoneal cavity is basically divided into a number of pockets which are separated by the folds of peritoneum. Those are the lesser sac, greater sac, and various folds of mesentery. You are just to know how the peritoneal cavity is formed and the anomalies related to it. You don't have to go into the much deeper details. This is for the PGs to go into the details of the peritoneal cavity, where they are asked about how the different folds of mesentery are there. So the visceral and the parietal layers, they are continuous with each other, and it's this dorsal mesentery is basically a thick band of mesoderm extending from the foregut to the hindgut, whereas the ventral mesentery extends only from the caudal foregut to the upper portion of the duodenum, and there is thinning of septum transverse. The mesenteries, they have the blood vessels, nerves, and lymphatics, and they provide a pathway to various organs. Then there is diaphragm. Diaphragm is basically developing so as to separate the thoracic with the abdominal cavities. Diaphragm is formed in the 6th to 8th week of intrauterine life, and it is because of the coalescence of septum transversum. So septum transversum is basically responsible for the formation of two structures. One is liver, another is diaphragm. Septum transversum is growing ventrally between the heart and the liver, and the pleuropericardial folds, they grow against the septum from the anterior lateral trunk wall. As you can see in the picture, the septum transversum leaves two open passageways on the left and right side. They are the pericardio-peritoneal canals. See, the arrows are showing you the pericardio-peritoneal canals. And these canals finally close to form the pleuroperitoneal membranes. And if these persist, then there is congenital diaphragmatic hernia. That is, the abdominal contents are herniating into the pleural cavities and they interfere with the development of lung. So you see here, this is how the pleuroperitoneal membrane is there. And this partition between the thorax and abdomen is completed when the pleuroperitoneal canals are closed by the pleuroperitoneal membranes. If you see that what all components are contributing to the development of diaphragm, they are, as you can see here in the picture, the septum transversum, pleuroperitoneal membranes on either side, and then there are dorsal and ventral mesenteries of the esophagus along with the mesoderm of the body wall. Some say that septum transversum is responsible for the formation of the central tendon, whereas some say that it is giving rise to the costal and sternal parts of the diaphragm. So there is difference of opinion between the scientists, and that is how the septum transversum is contributing to the development of diaphragm. This again the same picture. Omphalocele and gastroschisis we have already discussed when we were talking about the development of respiratory system. Cleft sternum is, there is a cleft in the sternum. Congenital diaphragmatic hernia. This is how the picture appears. It is present in 1 in every 10,000 births. And the abdominal contents, they herniate into the thoracic cavity through a gap in the diaphragm. Most common one is Bronchial hernia. It is located around the left trigonum lumbocostale. And it is effectively sealed by the liver on top of it. Another 5% of cases are those of organ hernia. That is present in the right side. So on the left it is Bronchial, and on the right it is Morgagni. Then the intestinal groups also may migrate into the thorax, and this diaphragmatic hernia is detected by ultrasonography. We'll have a look at the videos, how the development is taking place. See, this is it visible? Are you able to see this? Okay, Tasneem, thank you. This is third week of development where the gastrulation takes place. This is embryonic disc. That's how third week of development takes place. That is how the three germ layers are formed. Ectoderm, mesoderm, and endoderm form from the So this one is the development of trachea, lungs, and bronchi. Is it visible? Hello? This video has no sound. It is just the explanation that is labeled over it. The respiratory diverticulum, as you can see, the pharyngeal pouches are there. And then a section is taken as this level. So this is hypobronchial eminence and the tracheobronchial groove over here. Hypobronchial eminence caudal part is responsible for the formation of epiglottis, as I've already told you. This is the laryngeal inlet, that is from the tracheobronchial groove, or you can say the respiratory diverticulum. And the expansion is taking place. This is the bud that is formed from the foregut. It is endodermal in nature. So how the tracheal bud enlarges and then bifurcates. They invaginate the cavities from the middle aspect, and that is how the pleural cavities are formed. Right one has got 3 lobar bronchi, whereas the left has got 2 lobar bronchi, separated by the fissures. Yes, Faria? Any problem? So this is how the lungs are formed. I'm going to share you a link over here with the feedback form. Please fill it now. Meanwhile, I'm going to take the attendance, and you can go through the videos and the content in the Google Classroom. Yes, attend your roll calls. Between 1 to 50. Please
Roll
tell
number
me your roll
15.
numbers. Yes?
15.
1-5, Arsalan.
Yes, ma'am.
Roll number 7.
I'm 34.
I'm 1.
7 is Swapnil.
Yes, ma'am.
34 is
Atif. Yes,
Atif
ma'am.
Shaukat.
Yes, ma'am.
Then
1.
42 Faraz Hassan.
roll number 42, Faraz Hassan.
Roll number
Okay.
1.
Roll number 1.
Yes, ma'am.
क्या नाम है आपका?
Mohammed
Shahnawaz.
Shahnawaz.
Ma'am, roll number 28.
28, Tuba Shahid.
Yes, 36.
36, Laiba Imran. Then
43.
43 is Gagan. Then who else? Don't forget to fill the feedback form, please.
And 50.
Yes. 50.
Yes.
Afri.
Yes, ma'am.
Then anyone left between 1 to 50? 51 onwards, 51 to 100. Zainab Wahab was there.
Ma'am, 66.
Ma'am, 64.
64 is Sayyid Kabir Haider Zaidi. 66 is Tanya Tomar. Vishesh was there. Then
23.
73 is Talha Noor. Then who else?
Ma'am, 83.
33.
83. Sanya Reis.
83. Okay, सानिया रईस. सानिया अभी तक आप किसी क्लास में नहीं थी?
No, मैम थे अभी हॉस्टल से निकले तो वाईफाई कनेक्शन लॉस हो गया.
नहीं, इससे पहले आप किसी क्लास में नहीं रही शायद. Because I don't have your attendance anywhere in any of the classes. Okay. Who else?
Ma'am, 90.
90 is Mariam Salim. Then
Ma'am, 94.
94 is Tasneem Fatima. Then और कौन है? Between 51 to 100. Anyone left? Hundred one to 150. Zainab Rahman was there.
24 Zainab Javed.
128.
24 only, 120. Okay, 120. Zainab Javed. Then
114.
Sumayya was there.
114.
114. Amreen Tayyab.
Yes, ma'am.
Then
113.
who else? Yes?
113.
113 is Rashid Khalil.
116, ma'am.
Sir Ahmad.
126 Nikhil Varshan.
128.
126 is Nikhil. 128 is Shreya Jindal. Then
Ma'am, 138, Nosheen.
Noshin Niazi. Okay, then
128.
Shoaib Akhtar was there.
140, sir.
128. 128
Ma'am,
is Shreya
143.
Jindal. 146 Jyoti. और कौन है? और कौन बोला था अभी?
Ma'am, sir.
Vinay was there? Vinay Bharadwaj? I think he was there. Then who else? कोई रह गया? Anyone left for the attendance? अभी कौन बोला था? 128 हो गया. 128 हो गया, 138 भी हो गया. और तो कोई नहीं रह गया ना?